Bismillahirrahmanirrahim. Assalamu alaikum. This is Moise. My roll number is EP1770043. Today I am going to explain the chronic osteomyelitis. First we see the objectives to study the factors predisposing an individual for the development of chronic osteomyelitis, to know the common bones and type of organisms involved in chronic osteomyelitis, to study the outcome of causes after appropriate management. What is osteomyelitis? Osteomyelitis is a bacterial or fungal infection of the bone. Osteomyelitis affects about 2 out of every 10,000 people. If left untreated, the infection can become chronic and cause a loss of blood supply to the affected bone. When this happens, it can lead to the eventual death of the bone tissue. Who is affected by osteomyelitis? Osteomyelitis can affect both adults and children. The bacteria or fungus that can cause osteomyelitis, however, differs among age groups. In adults, osteomyelitis often affects the vertebra and the pelvis. In children, osteomyelitis usually affects the adjacent ends of long bones. Long bones, including bones in the arms or legs, are large, dense bones that provide strength, structure, and mobility. They include the femur and tibia in the legs and the humerus and radius in the arms. What causes osteomyelitis? It can be caused by a variety of microbial agents, most common in Staphylococcus aureus, and situations including an open injury to the bone, such as an open fracture with the bone ends coming out through the skin. A minor trauma which can lead to a blood clot around the bone, and then secondary infection from seeding of bacteria. Bacteria in the bloodstream, that is bacteremia, which is deposited in the focal or localized area of the bone. This bacterial site in the bone then grows, resulting in destruction of the bone. However, new bone often forms around the site. What are the symptoms of osteomyelitis? The symptoms of osteomyelitis can include pain, tenderness in the infected area, swelling, redness, fever, nausea, general discomfort. There are additional symptoms that may be associated with this disease include excessive sweating, chills, lower back pain, swelling of the ankles, feet and legs, loss or decrease of motion of a joint, etc. How is osteomyelitis diagnosed? To diagnose osteomyelitis, the doctor will first perform a history, review of symptoms, and a complete physical examination. In doing so, the physician will look for signs or symptoms of soft tissue and bone tenderness and possibly swelling and redness. The doctor will also ask you to describe your symptoms and will evaluate your personal and family medical history. The doctor can then order any of the following tests to assist in confirming the diagnosis. Magnetic resonance imaging, that is MRI. This imaging examination can show any fluid in the bone with greater sensitivity and precision. It is a helpful tool to see how far the infection has spread if present. Blood tests. When testing the blood, measurements are taken to confirm an infection, a CBC, complete blood count, which will show if there is any increased white blood cell count, an ESR, erythrocyte sedimentation rate, or CRP, reactive protein in the bloodstream, which detects and measures inflammation in the body. Biopsy. A biopsy of the infected bone may be taken and tested for signs of an invading organisms, etc. Osteomyelitis oral antibiotics, including IV treatment for patients with osteomyelitis from contiguous spread of infection, amoxicillin, clavulanate 875 mg, ciprofloxacin 750 mg, levofloxacin 750 mg. There are intravenous antibiotics of osteomyelitis that includes vancomycin is a glycopeptide. It is the most frequently used antibiotic for the treatment of osteomyelitis caused by Mr. Sa. Local antibiotics. The most commonly used antibiotics include gentamicin, tobramycin, and vancomycin. Gentamicin sulfate is an excellent additive to PMMA due to its broad spectrum of action. What is the look what is the outlook for patients with osteomyelitis? With treatment, the outcome for acute osteomyelitis or chronic osteomyelitis is often good. The outlook is worse for those with long-term or chronic osteomyelitis. Symptoms may come and go for years. Even with surgery, amputation may be needed, especially in people with diabetes or poor blood circulation. Prevention of osteomyelitis. One way to prevent osteomyelitis is to keep skin clean. All cuts and wounds, especially deep wounds, should be cleaned well. Wash a wound with soap and water, holding it under running water for at least 5 minutes to flush it out. To keep the wound clean afterward, cover it with sterile gauze or a clean cloth. Now there is conclusion, that is management of chronic osteomyelitis is a challenge for treating orthopedicians. Appropriate surgical interventions and suitable antibiotics for prolonged periods are required. Inadequate treatment is fraught with the danger of complications. Now we are going towards case study. Here we go. A 10-year-old girl complained about pain of the left knee after an accident sustained during trampoline jumping. The patient had a superficial skin abrasion, but due to decreasing pain, no doctor was consulted. 3 weeks later, she walked 35 kilometers in 3 days during a school trip, causing moderate pain of her left knee, mainly during night time. However, the pain was not associated with swelling, redness, or fever. The family consulted a medical practitioner and pediatrician and an orthopedic surgeon. Radiographs of the left knee were performed and no alterations of the patella were described. The patient was treated with NSAID. Subject: 10 years old girl. Chief complaint: she complained about pain of the left knee after an accident sustained during trampoline jumping. The patient had a superficial skin abrasion, but due to decreasing pain, no doctor was consulted. 3 weeks later, she walked 35 kilometers in 3 days during a school trip, causing moderate pain of her left knee, mainly during night time. Object: erythrocyte sedimentation rate 19 millimeter per hour. Anti-streptolysin titer 352 IU per ml. White blood cell count 8.750 per microliter. C-reactive protein 9.3 milligram per dl. Assessment: the girl was now referred to our pediatric orthopedic center. The girl presented with slight swelling of the prepatellar soft tissue and local hyperthermia of her left knee without joint effusion or fever. Biopsy and a swab were performed in general anesthesia using a ventral approach. Histological examination showed signs of acute osteomyelitis. The histological examination of the cartilage verified acute osteomyelitis, and Staphylococcus aureus was grown from the culture. Plan: additionally, the patient was treated with intravenous cefuroxime, fosfomycin for 12 days, followed by 16 days of oral antibiotics using amoxicillin and clavulanic acid. The left leg was immobilized in a long leg cast. Following a hospital stay of 17 days, the girl was discharged free of pain, and the immobilization was continued for another 2 weeks. 2 weeks later, the patient was seen in the outpatient department. She was free of pain, and the clinical examination of the knee was unremarkable. CRP and the white blood cell count were within normal ranges. The cast was removed, and the patient was sent home without restrictions for daily life activities. At the latest follow-up examination after 17 months, the girl was symptom-free with full range of knee joint motion. Thank you. Thank you very much.